Right, my name's Inkem Iro. I'm a pharmacist here at Regina SHA and one of the pharmacy clinical coordinators. And so myself and the Emerge doctors and the ID doctors and the antimicrobial stewardship program have been working together on a cellulitis PPO. And so in reaching out to them, I actually was able to find out that the family medicine residents actually did a QA study in the emergency room where they looked at subcutaneous abscesses and tried to figure out what our prescribing patterns were. And what they found was like 60% of subcutaneous abscesses were in those patients received antibiotics, even though antibiotics were not indicated. And so this presentation kind of ties in nicely because next month that'll be the discussion we'll be having is on the results and findings from the family residence study. So at this time, I have no final financial disclosures to make. And some of our objectives for today really is to look at what our local antibiogram is telling us. Specifically, I'll be looking at the Regina antibiogram. I'm going to discuss the diagnosis and treatment of cellulitis. Also understanding what beta-lactam allergy is and the cross-reactivity to cephalosporins, because that's a big part of the clinical picture and in deciding what antimicrobial will be used in our patients. And eventually apply all these learnings to a patient case, and I will finally unveil the draft. And this is a disclaimer, this is a draft of cellulitis PPO. I'm open to feedback or questions. You can email me if you have any concerns, and this will be at the very end. So I like to start off with a case. My first case is a 30-year-old male, and I just want you to hold on tight. Please mute your mics, please. Thank you. I would like to start off with a case, and I just want you to marinate on the details of this case and just hold on tight to deciding what you're going to do for this patient till the end of the presentation. So I have a 30-year-old male, 7-year history of IV drug use, and presents to the ER with a chief complaint of fever, pain, as well as redness to the right antecubital space. He states that he noticed the pain a few days ago, but he continued to inject in that same area. And also states that he's here because he feels that there's something round under the skin and it hurts really bad. So hence his presentation to the emergency room. So upon examination, it is noted that the area is poorly demarcated. It's red. The redness has spread to the forearm. It's warm and tender. This patient has no allergies. Vital signs, temperature is 38, heart rate is 110, respiratory rate is 22, patient blood pressure 101/60. So the first question is, what exactly is cellulitis? Cellulitis is an infection of the skin, infection of the deep dermis and the subcutaneous tissue, and usually it's usually poorly demarcated, and when it presents, it looks dilated, and its edematous skin, lymphatics, can be described like an orange peel look. It also has that clinical tetrad, which is there's usually pain, warmth, erythema, and swelling. 99.9 cases are usually unilateral and usually affects the lower extremities. However, it can affect upper extremities, especially in IV drug users. Some of the risk factors, a most common one is edema, most especially lymphedema. Intrinsic factors include age, so the older the patient is, the more likely to have cellulitis, or an obese patient, a morbidly obese patient is more likely to have cellulitis. Homelessness, which is self-explanatory. Some other risk factors include barrier disruption like trauma, ulcer, or wound, toe web infection. If the patient has had a history of cellulitis in the past, they're more likely to have cellulitis. The studies have shown about 50% more likely in the next 3 years if they have a history of cellulitis. So how do we diagnose this when the patient presents? The hardest part is being able to differentiate it from other kind of skin conditions, but cellulitis on its own is a clinical presentation. So a good history and physical should be able to figure out if this is cellulitis or not with other with other labs, but not labs. I take that back. In your mild, uncomplicated cases, there are no lab testings. However, if you have a patient that has a severe case or immunocompromised, in these patients, you could potentially do a blood culture. Skin swabs are not recommended. If there's purulence or if there's an abscess, there's also, it can be incised, drained, and cultured to tell you what the causative pathogen is. As regards to imaging, it's not diagnostic for cellulitis. However, it can help differentiate the different forms of cellulitis, or if there's bone involved and if there's some kind of necrotizing processes going on. So I have a picture of the different potential differential diagnoses. One that's very often confused with cellulitis is stasis dermatitis. This usually presents as a bilateral, it's usually bilateral, so like both legs. And like I alluded to earlier on, your cellulitis usually will be unilateral. So we always want to rule out other possible diagnoses. Another possible diagnosis is a DVT or a hematoma. A hematoma, usually you will see in patients that are on warfarin or have suffered a trauma to the extremities. Of note, misdiagnosis is usually as high as 33%. So when we look at our antibiogram here, specifically in vagina, and this is very important in your local areas to know what your antibiogram is telling you, because this will guide therapy. Overall, in vagina, 26% of clinical isolates of Staph aureus are MRSA, so very high for us. So what that means is approximately 3 out of 10 patients who do have a Staph aureus infection potentially will be MRSA. Clindamycin, I put this on here just because sometimes we have patients with beta-lactam allergies, and there's the question of should we give clindamycin or not. Our antibiogram in vagina, it has 82% MSSA susceptibility. For MRSA, it's up to 74%, so not great. You shouldn't be using clindamycin to cover for MRSA. And in your group A strep, it's 82%, meaning that if you did use clindamycin, you might not be covering about 20% of your patients. Trimethoprim, cephalotoctyl, I'm just going to call it Bactrim moving forward so I don't have to say a mouthful. It's intrinsically resistant to beta-lactam, beta hemolytic strep, and group A strep. Doxycycline as well is also resistant to your beta-lactam hemolytic strep. So this will be important when we go down the road and talk about what our options are to cover for streptococcus. Okay, so now when we look at our beta-lactam allergies, what is a true allergy? Because most times patients present and they tell you, oh, I'm allergic to penicillin. So we as clinicians need to be able to differentiate what a true allergy is from what an interaction, a drug adverse reaction is, and versus a not serious allergic reaction. So in our true allergies, you see an IgE mediated reaction. It's a life-threatening reaction where the patient cannot breathe, break out in hives, they have hypertension, angioedema, or wheezing. In these patients, we do not want to challenge them. However, if the patient tells you, I had diarrhea or nausea and vomiting, those can be classified as adverse drug reactions. If they say, well, it was when I was a kid or 10 years ago, in these patients, you can potentially challenge them with your beta-lactam. Of note, out of 1,000 patients that report that they have a beta-lactam or penicillin allergy, 100 of them will have a true beta-lactam allergy. And out of 100 patients that have a true beta-lactam allergy, only 1% of those patients cannot get a cephalosporin. So 1% cross-reactivity between penicillin and first-generation cephalosporins in actual patients that report penicillin allergy. So what this simply means is that in most patients, you can challenge them with a cephalosporin. And a good example here is in the hospital, we have patients who pre-op get cefazolin, which is a cephalosporin, and the pharmacist is verifying the orders and notices that, oh, the patient does have a penicillin allergy. 9 out of 10 times when you call up to determine what the plan is, the patient has already gotten this drug. And in my experience so far, I'm yet to find that one patient where it's been reported, oh, they got cefazolin and we had to intubate them. So this is really important when we start to look at all our choices for antibiotics. So I wanted to touch upon the different categories. So when you look at cellulitis, it can either be non-purulent or purulent. So in our non-purulent cellulitis, it's mostly beta hemolytic strep, specifically group A strep, and it can be classified as mild, moderate, or severe. In our mild cases, usually it's just your typical cellulitis, and the patient has no signs of systemic infection or illness, so they're not systemically sick. They just have cellulitis. In your moderate patients, they have cellulitis plus one or more serous criteria. And in the severe cases, they have cellulitis plus two or more serous criteria. Just as a refresher, serous criteria include temperature greater than 38 or less than 36, if they have a heart rate greater than 90, a respiratory rate greater than 20, or abnormal white count greater than 12,000 or less than 4,000. So when we look at treatments, in a mild non-purulent, so all they have is just cellulitis. They have no abscess. There's no pus. In this patient, the drug of choice, beta-lactams. You want to cover for strep. These patients can be treated as outpatients, and 5 days of therapy is usually enough. So our oral options include cefazolin, amoxicillin, cloxacillin, penicillin. Again, if the patient reports a severe beta-lactam allergy, and now we know what that exactly means, if we had to do an oral option, we could do clindamycin, keeping in mind that 20% of the time you might not be treating the patient effectively. And so if you choose to go that route, you want to make sure you're assessing and you have a plan for follow-up just in case it's not effective. So the other question is the overcoverage of MRSA. MRSA, I will say you don't need to cover in a mild non-purulent cellulitis situation. A study by Palin and co. looked at what they did was a multi-center study, and it was double-blind, and they gave patients that had simple, uncomplicated cellulitis either cephalexin or cephalexin plus Bactrim. And so these patients were outpatients, and when they did a follow-up, there was no difference in cure rate. 82% in the group that had the cephalexin, and 85% in the group that had the cephalexin plus Bactrim. The risk difference was about 27%. Confidential interval, 95% confidential interval was negative 9.35 to 15%, so not statistically significant. So what this is saying is really, if you have a patient, simple, mild, non-purulent cellulitis, beta-lactams by itself should suffice. In our moderate non-purulent cellulitis, the oral options will be the same, so still want to cover streptococcus. If the patient cannot take oral or if they failed on oral in the past, we have IV options. IV options are cefazolin, usually 1 gram IV Q8, and depending on how widespread the infection is, or depending on how sick the patient is, potentially we could do IV option as an outpatient. Another option is ceftriaxone. In this case, it will be 1 gram IV Q24. We're potentially covering more gram negatives than we need to, but it is an option. And then the question becomes, should we cover MRSA in this moderate case? Okay, in this case, I will say if the patient has a history of prior MRSA infection, or depending on how sick the patient is, if there's trauma to the area, potentially we could cover MRSA. And our options for IV will be vancomycin. If we wanted to do a PO option, if this patient is really sick, potentially just doing IV, but our PO options will be doxycycline or Bactrim in addition to cephalexin. So the severe non-purulent, in these patients, they have no pus, but however, they have 2 or more serous criteria. Emergent surgical inspection is required, debridement to rule out nicotizing processes, and you want to give broad spectrum IV. Most times, these patients will end up in ICU. In these patients, vancomycin plus peptides is an option, or meropenem. However, be aware that vancomycin plus peptides has an potential for increased nephrotoxicity. We also want to do a blood culture, especially when they're this sick, and try to tailor therapy to our results. I'll also recommend consulting an ID specialist in this case. Okay, so now we've talked about non-purulent cellulitis, and now I'm going to touch on purulent cellulitis. So in our purulent cellulitis, same scenario, it's cellulitis. However, there's the presence of pus, exudates, abscess, furuncle, or carbuncle. All this really means is that you have pus in addition to cellulitis. In this case, we're concerned about Staph aureus. So we want to cover MRSA or MSSA. Primarily, treatment will include incision and drainage, and then you always want to culture, and this should also help guide therapy in our severe cases. So we have the mild, moderate, and severe purulent cellulitis, which really is the same criteria, except in this case now we have purulent, so there's pus present. So in mild purulent cellulitis, we want to do the incision and drainage. No culture is required because this patient is really not sick, right? So all you're doing is removing the source of infection. And some people argue that you don't need antibiotics. But however, if you have that underlying cellulitis, potentially you could give a PO antibiotic which covers MSSA. So I will give cephalexin in this case. If it's a moderate situation, same as above, IND, CNS plus antibiotics. So our oral options is either MSSA coverage versus MRSA coverage. And how do you determine that? Empirically, if they're coming through the emerge room, just given the fact that we have a high rate of MRSA, it's not wrong to say that we could potentially cover MRSA orally by giving an oral med. However, what patients should you be looking at? Patients that have, again, had a prior history of MRSA infection and are known to have had that. Patients who have trauma, IV drug users, the ones like for sure empirically cover MRSA. And again, remember that we're doing an IND and CNS, and so we'll get our results back, and so we could potentially tailor the antibiotics to what our results are telling us. Our options include cephalexin if they have a severe beta-lactam allergy, potentially clindamycin, plus Bactrim or doxycycline. This is in your purulent cases. So we're covering that underlying cellulitis, the streptococcal coverage, in addition to staph coverage. If the patient has to get an IV option, if we just want to cover MSSA, your options are cefazolin. If the patient has a severe beta-lactam allergy, I will go for vancomycin versus clindamycin. The concern with clindamycin is C. diff, and we also have the concern of resistance as well. IV options for MRSA is vancomycin. So this slide is kind of busy where we have a bunch of options or route that we can go. There was a review of an article review that looked at cellulitis management in 5 urban Canadian emergency departments, and what they found out was that they had differences in practice, 25 different initial antibiotic regimens, and 40 different antibiotic regimens were prescribed to patients upon discharge. So what this really tells us is that despite having the guidelines, the IDSA guidelines, people have various ways in which they prescribe to treat especially the moderate purulent cellulitis, which is all dependent on clinical judgment or patient presentation and what your antibiogram is telling you. So all that has to be taken into account when we see these patients. So in the severe case, same as the moderate case, the IND, CNS plus broad-spectrum antibiotics. Your option, again, vancomycin plus peptides or meropenem. And then step down once your cultures are final. I will say also consult ID in these patients. Most of these patients potentially will be in ICU as well. So placement therapy, I just added this here because the 2014 IDSA guideline does talk about NSAIDs and its role. Studies that they looked at showed that when you prescribe an anti-inflammatory, patients tend to do better clinically. However, overall, long-term, there's no difference in the reinfection rate. So it'll help patients if you want to add an NSAID like an ibuprofen 400 to 600 Q8 or QID. One thing that's also very important is leg elevation. So you want to make sure the patient elevates their leg because this helps speed up the process of healing, and it's said to send down, like, true gravity help when we elevate our legs to our heart level, that true gravity, the fluid drains down and patients heal a little faster. So always don't forget to elevate the legs. So some of the clinical questions I would recommend whenever these kind of patients present to you include things like, is this truly cellulitis? Is it purulent or non-purulent? And if it's either or, what are the potential causative pathogens? If it's purulent, you want to, it's staph, more than likely. If it's non-purulent, it's strep. Severity, any presence of serious criteria in your patient. Your antibiogram, what is it telling you? Like, what is the resistant rates for those main antimicrobials that you're going to be using? Allergies, if the patient reports a penicillin allergy, is it a true allergy or is it an adverse drug reaction? MRSA coverage, we don't have to cover all our patients, but keep in mind, like in the Regina area, most especially, we do have a lot of MRSA. However, you can, based on what I've talked about, certain patients might be more high risk than other patients. Has the patient had any prior antibiotic use in the past? Should I give my patient a PO or should they go IV? And how to determine that is if the patient looks systemically well, there's no need to give IV, they can have PO. If the patient is systemically ill and hemodynamically unstable, or depending on how widespread that cellulitis is, then my choice will be IV. Is there a need for IND? This will be in your purulent cases. And if you're going broad spectrum, especially if coming through the emergency room, you want to step down therapy when you know exactly what you need to be covering based on your culture results. The POIV kind of still falls under your outpatient versus inpatient. If it's IV and you're contemplating outpatient, make sure the patient is organized and you can coordinate that with the patient. If not, and if they're not adherent to, potentially best to have them admitted to get started. And then follow-up. Follow-up would depend on how severe the cellulitis is. 48 hours is a good starting point, depending on severity. If it's mild, you can go longer than 48 hours. And just monitor. One thing us as practitioners need to be aware of is that cellulitis will get worse before it gets better. Usually when you give the antibiotics, the pathogens usually, because of the bactericidal effect of antibiotics, the lysis causes all the toxins to spread. So it looks worse than it, even though the patient might be reporting that, oh, I'm feeling a little bit better. Try not to always just look at the cellulitis itself because it will get worse before it gets better, and monitor other parameters, not just what the picture of the cellulitis is looking at in that moment. So now going back to our case, a 30-year-old male, 7-year history of IV drug use, presents to the ER with a chief complaint of pain and fever, as well as redness to the right antecubital space. He noticed the pain a few days ago, but continued to inject in that area. He states he's here because he feels something round under his skin and it hurts. Upon examination, the area is poorly demarcated, the area is red, and the redness is spread to the forearm, it's warm and tender. He has no allergies. Vital signs, temperature is 38, heart rate is 110, respiratory rate is 22, blood pressure 101/60. I don't know if I should go to remote sites. If anyone wants to take a stab at this as to what they're due is, are they able to, I guess, answer? Okay. Feel free to state what you would do in this patient, given what we just talked about. And if I don't hear anything, then I'll pick on the people in front of me. Okay, I don't hear anything. Does anyone want to try here?
Vancomycin, maybe?
Okay, so should we go through our questions first, before we, why Vanco and why cefazolin? Oh, your mic.
So I'm thinking a combination of Vanco and cefazolin, just given his previous IV drug use history. He's more at risk for MRSA, so we'd want to cover that. And then vancomycin doesn't kill quite as well as cefazolin does, or have as much of a bactericidal action. So the cefazolin on there would be covering more of your MSSA if it was more likely the predominant organism. Plus, it's more bactericidal for the potentially strep.
Mm-hmm.
Yeah, so that's kind of what I'm thinking initially.
Okay, for sure. You get a candy. I brought candy. So now everyone has to answer a question.
If the abscess is...
Should I throw it? Yeah. There you go. Oh, I don't have a good aim. So when I look at this case, the first question is it truly cellulitis? And given the presentation, there was a port of entry, right? The patient is an IV drug user. Patient states that there's pain, it's warm, it's red, so it has all the clinical signs of inflammation. They do have a fever, temperature is 38, patient's heart rate is 110. So they already meet at least two criteria for meets two serious criteria. And if we recollect, the patient said they felt something hard under the skin that was round. So that potentially is some exudate or pus, potentially. So we need to do an IND, so incision and drainage, and then culture that. And I agree with Casey, we can potentially do IV Vanco and cefazolin, and then tailor down our therapy when we get the results from the culture itself. Okay, any questions? Okay, I have one more case. I think I have time for one more case. So case number 2, 49-year-old male with history of diabetes presents to the ER with chief complaint of pain and redness to the left leg. States that the pain has gotten worse, as well as the redness and swelling. He lives at home with his wife, and he does have a family physician. Upon examination, the area is noted to be red, warm, and swollen. Patient has no fever. The vital signs are within normal limit. And the bedside ultrasound showed no fluid collection. Patient has an allergy to penicillin. Okay, remote sites. Can someone try and see? What will we do for this patient? I need at least one person, so I know someone's listening to me. And it doesn't matter if it's wrong. I just can guide the answer to as well.
This is Leland, nurse practitioner. What is the penicillin reaction?
Yay! I wish I could give you a candy too. That's the first question. What is the penicillin reaction? So the patient states they don't remember. They were a kid. The mom told them, his mom told him when he was a kid that he had a penicillin allergy, and so he doesn't recollect. States that he doesn't remember being hospitalized for this reaction. The mom never told him of any severe. There were no severe findings as regards to reaction. Just the mom just never gave him penicillin because he had a reaction to it, but he doesn't think he was admitted into the hospital.
And I'm assuming it's unilateral from the assessment.
Yes, it is.
Okay. And if we assume a normal renal function, he's fairly young, but we know that probably his integument, because of the diabetes, maybe it isn't 100% and puts him at increased risk for infection.
Okay.
Probably Keflex, I would challenge with the Keflex Q80, 500 milligrams for 5 to 7 days.
Awesome. That's the right answer. So this patient, vital signs are within normal limit. Patient has no fever. I'm not concerned about the penicillin allergy that has been reported. So my choice of antibiotics will be an oral choice. This patient does not need to be admitted in the hospital. The patient also has a family physician, lives at home with his wife. So I'm not concerned about, if he needed to go for follow-up. So my choice, and number one choice, would be cephalexin, 500 milligrams POQID, 5 days. If I need to extend it, 7 days. Of note, you shouldn't be treating any kind of cellulitis more than 10 days, except that the patient is immunocompromised or on chemotherapy or neutropenic. So duration of therapy, I would say 5 days, at most 7 in this patient. Okay, so I have the PPO here. I don't know. Let's see. I hope he pulls up. I was trying to be like tech savvy here and connected to this, but oh God, I knew it might not work. No, okay. I saved it. I put it on the desktop as well, so I should be able to. Will it not let me go out of it to go to the desktop? I can, okay, yeah, for sure. Yay. Oh, let's see. Oh, yeah, it'll probably let me do. Oh, it won't let me pull it up. Okay. Well, I have it on my desktop. So, I don't know why it's giving me 2 windows here, like this way. Let's see. Interesting. Okay. So, like I said, we've been working on our PPO for cellulitis. It's not official. But the way this PPO was designed, I was trying to make it just
drag it over. If we want everyone to see it.
Oh, okay. Oh, you mean like to see it up there? Okay.
Yeah.
Sorry.
Here's what we got to do. I'm going to move it right, and now they can see it there.
Okay. Awesome. Okay. But now I can't see it. Okay. Anyways, so the PPO really is broken down to what we've talked about, the non-purulent and the purulent part of it, and it gives you your options of antibiotic choices, pretty self-explanatory. And it's broken down into mild cellulitis, and I won't be able to, yeah.
Yeah, because we're using presenter notes.
Oh, okay. And it's broken down into mild cellulitis and the moderate cellulitis and severe cellulitis. And so we're hoping to just have it at 2 pages. It is a draft. It gives you the option. No, no, it's okay. I was just trying. Oh, I can move it on. Okay. So I was just going to show real quickly. So non-purulent, purulent, and then you have your options of beta-lactams. And if they have a severe beta-lactam allergy, potentially clindamycin. But you should be doing a cephalosporin unless, like I said, it's a severe beta-lactam allergy. And then if you're concerned about MRSA, then that's the option. And then in your purulent cases, if it's mild, you may or may not need antibiotics. And if you do, it's PO. And then if it's non-purulent and it's a moderate case, it tells you up there and gives you the criteria that needs to be present. It gives you options of antibiotics, mostly PO. However, if you determine that the patient has to have IV, it breaks it down into your options. You should not have to do 2 grams IV Q8 unless the patient is morbidly obese. There's also the option of outpatient treatment in this in the moderate cellulitis. And then vancomycin. And then in the severe cases also, we have the vancomycin, Piptaz, or meropenem option. Of note, if the patient has a severe situation, we want to always consult ID. Okay. See if I can go back into this.
You have to launch it again. If you hit F5,
Okay. Awesome.
you have to find your page again.
Okay. So another thing that we worked on was an algorithm that also breaks down, really the whole presentation is in this algorithm. It breaks it down into purulent, non-purulent. It does a systemic sign of infection, yes or no. And then you can break it down into mild, moderate, and it gives you your options for therapy. If you're suspecting MRSA, if yes, if no. So I want to say a big thank you also to Antimicrobial Stewardship for helping initially put this algorithm together, and also Bev, who's our pharmacy administrative assistant coordinator, who helped me add the other part of it. Like I always have a vision, but just to put it out in picture is always like hard, but they were like instrumental in having this done. So if anyone would like this copy, this again is just a guide into how we treat cellulitis. I think it's helpful. So in summary, what I would like to leave everyone to leave with today is, first of all, we must know what our local antibiogram is telling us that guides therapy. Investigate and assess if the patient has a true beta-lactam allergy. Clindamycin is not a good option because of GI issues and C. diff, and also our resistant patterns. I want to make sure everyone is aware that doxycycline or Septra or Bactrim or trimethoprim sulfamethoxyl have poor beta hemolytic strep coverage.
Code blue, outside emergency. Code blue, outside emergency. Code blue, outside emergency.
And then you also want to determine severity. Are they systemically sick? Do they meet any serious criteria? If it's a purulent case, IND and culture and susceptibilities. And duration of therapy is 5 days, no more than 10 days, and 5 days and reassess. Another thing I should have added to this slide is cellulitis will look worse before it looks better. So not just looking at what it looks like in that moment, but assessing other parameters as well is important. My references. And so now I'll open it up for questions. The WebEx, if you have any questions, and remote sites.
Hi, it's Linda. I was just wondering if how we can obtain that algorithm, because that looks really good.
Oh, okay. Yeah. Okay, so 1 second.
Hi, it's Robert Parker, the manager to the Stewardship and Clinical Appropriateness Program. If you want to just email a request to the antimicrobial.stewardship@Sask Health Authority email, then we can forward it out through there.
Okay, thank you.
Okay, any more questions? Okay.
Hi, can you hear me?
I can hear you.
Hey, it's Kieran Conway in Lestock. I just noticed that you put as reasonable alternatives for non-purulent cellulitis, ceftriaxone and cefazolin. I'm just wondering what you lose when you use ceftriaxone.
So for non-purulent, sorry, go ahead.
Because presumably we're assuming if we've got non-purulent, we're thinking this is going to be a gram-positive bug. I see a lot of people using ceftriaxone just because it's easier, it's more convenient, it's the dosing is nice, you can keep people at a hospital, which are all good, but I'm just not sure. I guess I'm wondering your take on their equivalency, because I don't necessarily see them as equivalent.
Yeah, and all the reasons you've mentioned are one of the reasons why we see it too. Ceftriaxone, you don't lose your strep coverage, which is what you're looking for, right? And you also have the MSSA coverage. Now it's broader, where you now have gram-negative coverage. It is listed in the IDSA guideline as an option. that's not my first choice to go to, but like you've kind of alluded to, it is dosed every 24 hours. So some doctors might like that option, but is it great prescribing or antimicrobial stewardship? I would not say so. But if you have a patient where they don't want to do the Q8 or and they're in hospital, it's interesting, and I see your point, and I agree with everything you've said. And that wouldn't be my number one choice. I will go for cefazolin first, but I just listed it on there for completeness. However, I have not. I didn't put that on the PPO just because I don't want to encourage that as a practice. So it's not listed on the actual PPO for cellulitis. But if you do look in the literature or in the guidelines, it is listed as an option. Well, did that answer your question?
Yeah, no, I just was always under the impression that, like, in my practice, not to, as tempting as it is, not really to use ceftriaxone as first line, because over concerns that you're missing out on some of that gram-positive coverage. But you're saying not really; it's just other issues related to stewardship that we kind of want to keep the ceftriaxone for other indications. And is that right, or?
Yes, that is right.
Yeah. Okay.
Yeah.
Thanks.
You're welcome. Okay. No. Okay, not hearing anything. I'll at my present site. Any questions?
I just had one comment about the last question there. Really good, and this is something that comes in the hospital quite often as well, as cefazolin versus ceftriaxone. And you're right, where you're not losing that strep coverage, but ceftriaxone isn't as quite as potent as something like cefazolin or cloxacillin, specifically for strep. So if you're, for staph. So if you're going after staph, cefazolin is always going to be a better choice than the ceftriaxone. And just one other point about the sort of the third generation cephalosporins is they're also implicated in pushing your resistance rates, or actually contributing to VRE as well. So there is some, some damage you can cause in other areas as well if you're always using ceftriaxone. But it is a good pragmatic option for getting people home and continuing them on reasonable therapy.
Great. Well, thank you very much, NChem. And on behalf of the Antimicrobial Stewardship Program, we're very happy to be collaborating with you and engaging on this project that you're working very hard at. The work has been excellent. And if there's no other questions from the communities, then that'll be all for today. And there will be a posted video of this presentation on our website, hopefully within the next couple of weeks, if there's somebody you wanted to refer to. And again, those documents, if you wanted a copy, just send the request to antimicrobial.stewardship@Sask Health Authority, and we will get those off to you. Thanks very much, everyone.
Thanks, guys.